Okay, everybody, let's just get going here. My name is Dana Murphy-Parker. I'm the president-elect of the International Nurses Society on Addictions, and really looking forward to hearing this presentation this morning by Brian Hurley, initiating buprenorphine for patients. Just for your information, this is a list of all the partners for the PCSS grant, which is the Providers Clinical Support System. And it is a grant that is funded by SAMHSA to all of these professional addictions organizations in our country. And all of them do webinars as well that are free on the sites, on the PCSS site. And certainly the ones for INSA are free on our sites. So it's just terrific work. Check them out if you have a question about anything. They're usually covered just about anything with opioid use disorder. The overarching goal of the PCSS grant is to train healthcare professionals in evidence-based practices for the prevention and treatment of opioid use disorders, particularly in prescribing medications for opioid use disorders. They have a mentor program. There's a link down there. They're offering to answer questions or to set up some of the mentors one-on-one with anyone who's interested in learning more about how you set up programs for medication-assisted treatment for MAT programs. There's also this link where you can put a question in, ask a colleague. It's a very nice way of being able to get an answer on questions that you have. Okay, so they educate, they train, they mentor, and I got to tell you, they do really fabulous, fabulous work. This grant has been going on for probably about 4 years now. And it is just very, very excellent work from so many different organizations and professionals. So let me go ahead and introduce to you Brian. Brian is an addiction physician based in California and the medical director of the Division of Substance Abuse Prevention and Control for the Los Angeles County Department of Public Health. He currently serves as the president-elect of ASAM, the American Society of Addiction Medicine, and he is slated to be the president at their April annual conference, which is going to be in Baltimore later this month. He's the clinical director of the Addiction Treatment Starts Here program through the Center for Care Innovations, focused on increasing the delivery of medications for addiction treatment in California's community health centers. He's a senior researcher at the Friends Research Institute and is a primary investigator on a tobacco-related disease prevention program funded project integrating smoking cessation services in community mental health centers and patient centers medical homes. Additionally, Dr. Hurley is the grant lead for several medications for addictions treatment access point projects funded by the Sierra Health Foundation, supporting access to medications for addictions treatment across the Los Angeles County. He's on the faculty at the University of California, Los Angeles, as a volunteer assistant clinical professor of addiction medicine in the Department of Medicine. Hello, Brian. Yay.
We ran into a time zone issue. I thought it was noon Pacific, so I had to step out of it.
Oh, no.
It's all right. You know what? We have a good group assembled here.
Yes, we do.
My thought is, why don't we go through what we can go through in the next 40 minutes? Does that sound okay, Dana?
I think that's perfect.
Sorry I'm late. Forgive, I had the time zone reversed in my head. So I'm Brian.
Thanks for being here.
Of course. Addiction psychiatrist.
I did your bio.
All right, cool. All right, so we'll go ahead and jump in.
Okay.
I don't have any financial conflicts of interest, although I'm the president-elect of ASAM, and so I will probably be unbiased with respect to ASAM. So we're in the biggest overdose crisis in U.S. history, driven by fentanyl. And I know that there's been a lot of discussion about how what do we do to help address the overdose crisis? And, only 6% of people with substance use disorders actually voluntarily goes to treatment, right? When I say voluntarily, signs up and participates in specialty SUD treatment. And the biggest driver for why people don't go to treatment is they don't feel like they need it. Now, the percentage of people with opioid use disorder that get on medications for opioid use disorder is somewhat higher. The treatment gap isn't 95%, it's something like 78%. But we're still in a treatment gap for people with opioid use disorder. And part of that is driven by, again, lack of access and wanting to make sure that not just addiction clinical professionals, but that essentially every part of the healthcare system, emergency departments and primary care practices and street medicine practices and community mental health centers treat opioid use disorder, and medications, again, are a first-line treatment for opioid use disorder. So there's 3 FDA-approved meds: methadone, buprenorphine, and naltrexone. And I'm going to talk mostly about buprenorphine, mostly because it can be managed outside of an OTP, or a federally licensed opioid treatment program, and because it is easier to initiate buprenorphine than naltrexone. Ease of initiation is a well-known advantage of buprenorphine. All right, cool. So here are the FDA-approved formulations of buprenorphine for opioid use disorder. You'll notice some of them are split between buprenorphine with naloxone and buprenorphine without naloxone. They come in tablets and films, and there is also a monthly injectable format. All right. Why buprenorphine? Huge reductions in mortality, right? Over 4-fold reduction in reduced overdose and mortality risk associated with being treated with buprenorphine for opioid use disorder. And people who are maintained on buprenorphine stay in treatment for longer and are more likely to be opioid negative over the past month. All right. So this is from the classic PCSS waiver training slide deck, that, the major feature of buprenorphine is this partial agonism, this high affinity partial agonism. Now, buprenorphine, like methadone, has a long half-life, but unlike methadone, will precipitate withdrawal. And that's these like pink arrows. You get precipitated withdrawal if you take buprenorphine while you have an active blood level of a full agonist opioid, like morphine, methadone, fentanyl, or another opioid. If you take it while your blood level's too high, you'll notice some precipitated withdrawal. And it's the timing of when people start buprenorphine that is the key feature. Now, in an era where, oxycodone or hydrocodone were the most used opioids or misused opioids in the US, and where heroin was the most used illicit opioid in the United States, it was pretty easy. And I'm going to go over what I call the classic buprenorphine initiation. What is the standard? And the classic buprenorphine initiation was stop using opioids. The rule of thumb was within 12 to 16 hours for short-acting opioids, 24 hours for sustained release, the contents, right, MS-Contin or OxyContin. And within 36 hours of methadone, somebody should begin to be in enough withdrawal to not have precipitated withdrawal. And that was always sort of the classic guidance. Now, in the slide deck, be aware of fentanyl, and you want to make sure somebody really is in moderate withdrawal. And many of you are familiar with the COWS scale, the clinical opiate withdrawal scale. It's an objective scale you can use to quantify withdrawal features. The first dose of buprenorphine was, between 2 or 4. Again, this is the classic initiation, right? So I always taught people 2 milligrams every 2 hours. But you could go to 4 milligrams in a patient that, if you were dealing with the 8, 4 was also kind of an acceptable starting dose. Relief of withdrawal starts within 30 to 45 minutes, and then redose every 2 to 4 hours as needed for withdrawal features. And then you stabilize a dose that eliminates cravings, typically between 8 and 16. This was the classic buprenorphine instructions. And then if somebody needed a higher dose over time, that would be okay. However much somebody took on day 1 was the amount that they would take on day 2. And, you were usually doing daily check-ins with patients who were doing this process at home. And the idea is you wouldn't necessarily want to do a rapid dose adjustment. If somebody was on, say, 12, you wouldn't want to go to 24, right? You would, do 12 and then maybe 16. You would adjust in dose increments of 2 and 4. And this is, again, the classic instructions on buprenorphine initiation. And also the classic instructions were most patients do find them between 8 and 16. You could go up to 32. Many insurance companies limit to 24, but anything over 16 is at risk for diversion. Again, this is like classic waiver training kind of 101 type stuff. And then there's this article, and it's this wonderful article by Sydney Silverstein's the first author. Everything is not all right anymore, right? Like, so we had like the classic instructions, and then we found that like buprenorphine in an era of fentanyl. I'm going to try to move. Sorry, I'm going to try to move this bar to make sure that it's not in the way. All right, cool. Everything's not all right anymore. Buprenorphine in an era of fentanyl. We're noticing precipitated withdrawal even in instances where you wouldn't have expected. So what is it about fentanyl? So fentanyl, first of all, is really potent, right? As potency go, it's a high potency opioid. Now, buprenorphine has a higher affinity than fentanyl usually. Carfentanil, which is like super high potency fentanyl, begins to approach buprenorphine's kind of level of affinity. And then you get like super high affinity fentanyls like alpha fentanyl or sufentanil or other types of fentanyls that we increasingly see in our drug supply. And Jerry, I appreciate you bringing up the smaller dose of Zubzol. I'll make sure it gets updated on I got that from PCSS, but I'll make sure it's updated on the slide deck. So the other thing about fentanyl, it's got a relatively short half-life, but so the half-life is again 2 to 4 hours, but with a very rapid decline. So people use it, but then fentanyl gets sequestered into adipose tissue. And so the actual clinical effect is felt very brief. But then if you start looking at, well, how long does it actually stay in your system? We saw instances where it took, 1 to 2 weeks, or like a week to clear fentanyl from urine toxicology testing and 2 weeks to clear norfentanyl from urine toxicology testing, which really suggests the pharmacokinetics of fentanyl behave a little differently than a short-acting opioid. So I'm going to cover like, where are the alternatives to the classic, right? What are the alternative ways of starting buprenorphine compared to the classic buprenorphine initiation? So I'll cover high-dose starts, low-dose starts, what to do with patients who might be in a controlled setting and away from opioids. And Dana, I'm really curious, I'm looking forward to discussing this with you, the how we do controlled environment starts. And then for people who have pain, where you are now allowed to use opioids FDA approved for pain and not opioid use disorder, what other options there are? And I could go on and on. For any of these all deserve their like a 1 hour talk. So I'm going to kind of cover the basics of them and then point you towards additional resources. Okay, so high dose starts. For those of you familiar with the California Bridge program, and I live and work in Los Angeles, so I'm familiar with the California Bridge program. This is the classic quick start guide. It was updated when the waiver was eliminated to, includes an X waiver is no longer needed to prescribe. These quick start guides are specific to hospitals. So just to be clear, these are like built for hospital clinicians. I work in a health system that we adapted this for ambulatory settings, and I'll go through kind of the instructions that we had. But it goes through like starting buprenorphine at a high dose because people coming off of fentanyl have a high opioid tolerance, and where 2 milligrams may not cut it, right? So they recommend starting at 8 or even 16 the first dose, like literally 2 tablets or films under the tongue, like as a first dose, and then wait an hour, and then administer a second 8 to 16 up to a dose of 32. So you could get up to somebody 32 in like 2 hours. Now, what if you precipitate withdrawal? This is the question. Now, when I talk to the California Bridge, they're like, well, we're in an emergency room. So like if they're vomiting, a Dancitron. If they're, tachycardic, alpha-2 agonist like clonidine. If they're really activated, you could use a benzo. Why? You're in a controlled environment, right? Where benzos like sedatives like benzodiazepines in a monitored setting are much, much safer than having somebody apply a supply of sedatives. And then they also have like a ketamine, 0.3 milligrams per kilogram, where you literally would put somebody into conscious sedation briefly to help them get through precipitated withdrawal. So I wanted to highlight that this is a high dose protocol built for efficiency, right? You get people up to a high blood level as fast as possible. You can't precipitate withdrawal, but you manage it. And they actually published, this was their outcomes paper of just under 500 patients treated with this protocol. And they were able to identify roughly 10% of those patients here in California who were confirmed to be using fentanyl from toxicology testing. And so they did an analysis. How well did the people who were treating with buprenorphine that we didn't confirm were using fentanyl compared to the people who were? And again, it's not a 50-50 comparison, right? This is a case series. So you don't have full randomization. So, and it's largely from the medical records, there's all these limitations. And I apologize for the text. I didn't have a better figure from the paper to show. But of the roughly 500 patients who showed up and were administered buprenorphine, almost all of them, like 90% of them, were initiated on high dose buprenorphine. Their first dose was 8 milligrams or above. Precipitated withdrawal was observed in 8 of those cases, right? So this concern that like precipitated withdrawal is going to be universal and everyone's going to have it actually was relatively rare. 2 of those cases were in the fentanyl group, so that's 1 in 20 of the fentanyl cases. There was none of them required hospital admission. So you can read case reports of horrific things that can happen with precipitated withdrawal, like pancreatitis and other things that require admission. But the truth is, none of the cases required hospital admission, and 4 of the patients who were using fentanyl had follow-up at 30 days. That is, they successfully transitioned when loaded on buprenorphine to a bridge clinic where buprenorphine was continued. So how does that compare to people who report fentanyl use as compared to people who report other opioid use? And the odds ratio actually crossed 1 in every measure. So there was not a statistically significant difference in whether somebody received buprenorphine actually administered or prescribed in the ER. No significant difference in follow-up at 7 and 30 days. And so they conclude there was really no significant difference in follow-up engagement except for fentanyl use and precipitated withdrawal, even in the case of fentanyl use. So the idea that if somebody's using fentanyl, you can't use a high-dose regimen or like it won't be tolerated, did not bear out in a hospital setting. Let me be clear, it's a hospital setting. This was a handout that's adapted for ambulatory settings. And this is LA County's public health system. In the LA County public health system, we don't use cows because it's hard to self-administer. And sows, which we could have used, is oftentimes not at a literacy rate that is commensurate with the populations we treat. So we use pictures and then just like a list of symptoms. And with a rule, if you have 3 or more of these symptoms, you're ready to start buprenorphine. And then the universal prescribing is the 8 milligram tabs or films. And the instructions take half or 1 every hour until the withdrawal cravings are gone. So this is, again, an adaptation of high-dose sublingual buprenorphine with a cap at 32 milligrams. And this is, again, the way the handout is structured. So sublingual, no more than 4 of the tablets or no more than 4 of the films in a 24-hour period. So an adaptation to the high-dose protocol. Now, LA County does not track and follow follow-up for these patients the same way the California Bridge program did. So there is no outcome data for ambulatory settings. I will say that I have heard plenty of anecdotal reports of people having precipitated withdrawal and feeling uncomfortable, and oftentimes needing some additional support in an era of fentanyl to be like supported taking enough buprenorphine in order to alleviate their withdrawal features. And then I do want to highlight there's also a role for buprenorphine injection. There is a trial of 5 patients treated at Columbia, New York. This is just a schematic of extended release buprenorphine injection and schematic of the different blood levels of buprenorphine that happen with the standard initiation, which is 300, 300, and then 100 thereafter, versus 300 q month, where you get the sort of escalating blood level of buprenorphine over time. So again, there were 5 patients in an open label protocol followed for 12 weeks, where a sublingual buprenorphine was administered to people in the clinic. Cows was evaluated until it was 6 or above. They were given 2 milligrams of sublingual buprenorphine, and then in another hour given 6, and then another hour given 8, and then another hour given 8. So everyone was sort of loaded on 24. They did a sedation scale to make sure the person wasn't too sedated. If they were too sedated, they would hold the next dose until the sedation wore off. And then 1 hour after that 24 milligram load, they received the extended release buprenorphine injection, 300 milligrams. So that was like a essentially much more accelerated transition for people from like using whatever opioids they were using to injectable buprenorphine. They then offered the standard dosing. So after a month on buprenorphine 300 milligrams, they got another injection of buprenorphine 300 milligrams the next month, and then 100 milligrams the month after that, and then followed for 4 weeks following the third injection. 100% were chained in treatment and received all of the injections. The acceptability of the single day start on buprenorphine injection was high, and the longest period of illicit opioid use was 5 days, which was pretty good. So it like significantly reduced opioid use. The authors conclude this is worthy of further study, right? Like this is like a way of transitioning people onto injectable buprenorphine, but again, worthy of further study. That's high dose buprenorphine in a nutshell. What about low dose buprenorphine, right? Okay, so this is a schematic from a review article looking at, precipitated withdrawal. Like the top set of graphics is the classic precipitated withdrawal where you use, doses of buprenorphine like 2, 4, or 8, and it displaces the full agonist opioid that somebody has been using, and it causes precipitated withdrawal. Whereas, what if rather than having a patient stop using, go through withdrawal, and start buprenorphine, what if a patient kept using, you start a low dose of buprenorphine, slowly titrate up, and then the person kind of comes off of their opioids, so to bypass that withdrawal. So that's what I'm going to talk about next, is protocols to do that. And it's called bridging at the molecular level is what the authors talked about. But again, low doses of buprenorphine that kind of gradually displace full agonist opioids over days as opposed to over minutes. So this is not exactly the Bernese method. Many of you probably heard of the Bernese method. This is a chart that is a very slight modification of that. But one advantage to this is using doses that you can get with commercially available 2 milligram tablets or films. Whereas the classic Bernese method was using like 0.1 milligrams or was using milligram strengths that require formulations that we don't have easily available. Although my colleagues, the 0.7 Zubsolv is another potential option to achieve those low doses. Okay, so but for non-Zubsolv formulations, 0.5 milligram once a day for day 1, 0.5 milligram twice a day, day 2, 1 milligram twice a day, day 3, 2 milligrams twice a day, and then they just stay on whatever they stay on using fentanyl or stay on using whatever opioids they're on as you gradually titrate up until you get to when you get to 4 milligrams TID, that's like 12 milligrams. That's a decent dose of buprenorphine, and at that point, you're the person really could now much more easily tolerate a transition off of whatever they're using, because at that point, when you're on 12, you can easily get to 16, or if somebody is, because they're tolerant to a high dose of fentanyl, if they really do need a higher dose, you can titrate to that 24 or higher dose. So this is, again, a different schematic, slightly different author. At this point, there's like, I think I counted 15 low dose protocols. Most of them are case series. Very few of them are randomized controlled trials. So we don't have a lot of good trial data, but we do have a lot of like protocols that have been tested in the field. So again, this would be like 0.25 milligrams daily, which you have to go with a different formulation in order to get there. Then 0.25 milligrams BID, then 0.5 milligram BID, 1 BID, 2. So it's essentially this like doubling every day. And the vision is as somebody gets to like 8 milligrams a day, 12 milligrams a day, 16 milligrams a day, that's going to be a dose that's going to hold them and they can come off of their full agonist opioid. Here's another chart, sorry for all the text, of like different buprenorphine naloxone dosages, option 1, 2, and 3, based on different formulations that are available. And again, this was from our colleagues up in Canada, the Canadian Family Physician article. And they also do recommend, like for ambulatory settings, clonidine, ibuprofen, diphenhydramine, loperamide are all considerations that people can use if there is any precipitated withdrawal symptoms to help like somebody have other tools. And then also consider dosing higher doses of buprenorphine naloxone if the person does have precipitated withdrawal, because you can get some relief from higher doses of buprenorphine. And then, so here's Dr. Bloom, I want to thank Dr. Bloom and thank Dana for graciously coordinating. I have to give him credit for the slide deck of just kind of a standard set of comfort meds that we use. Just one thing with loperamide, at super high doses, it can behave like an opioid. So like you can prescribe it, but just generally speaking, not a ton of high doses for people. All right. Pain management and analgesic dosing. So it is a violation of the Harrison Narcotics Act to prescribe Butrans, which is the trade name for transdermal buprenorphine, for opioid use disorder, right? And there are other like Buprenex, which is the trade name for short-acting injectable buprenorphine, any of which could be feasibly used, and actually in other countries where there's more flexibility on the use of opioids, FDA approved for pain to treat addiction. I mean, there's other places where like hydromorphone is used to treat addiction, right? Like it is not as restricted. But with Butrans, essentially, it's you put on and this slide I got from Dr. Bloom, although it comes from Matt Perez up in Washington, and essentially based on some estimate of what's the morphine equivalent dose that the person's taking in every day, you would put on the like low dose patch, which is 5 micrograms an hour. For middle level morphine equivalents, it would be the 10 milligram patch, and then for higher level, like 90 or above, it would be the 20 microgram an hour patch. And then so you put that patch on, it gives somebody a low level of low blood level of buprenorphine during the first 3 to 4 days. And in fact, actually, the patch is taken it's a weekly patch, so you keep it on for 5 days. They stay on their regular opioid, and then you start low doses of sublingual buprenorphine, again, like a quarter or half of a 2, that slowly titrates up. And then as the patch comes off, at that point, you're on doses of sublingual buprenorphine closer to 8, and you stop on day 3. So this is a schematic of how like the patch plus sublingual buprenorphine can be used to kind of bridge to each other. Again, transdermal buprenorphine is FDA approved for pain and limited to that indication. Here's a 3 and 7 day versions of that. Again, this is a Canadian Journal on Addiction that covers some variations. And then here's again from Dr. Perez of doing sublingual buprenorphine, actually not after you start the patch, but in parallel with when you start the patch would be another option. But again, transdermal buprenorphine, FDA, you have to have a pain indication or prescribe that. And then somebody kind of slowly comes off of their old opioid that could include fentanyl. And again, this is a way of helping ease somebody into buprenorphine without overtly precipitating withdrawal. Just as a quick note, if you are using buprenorphine for pain, buprenorphine has an alpha phase and a beta phase, and the analgesia is really just during this higher level plasma concentration or alpha phase of the dose. So buprenorphine for pain is like a TID med, a 3-time-a-day med. Buprenorphine for addiction is usually once a day. And so I have patients in pain, 4 milligrams QID, 8 milligrams TID. These are not uncommon doses for people in pain if I'm trying to now use buprenorphine for both its analgesic properties and its opioid use disorder properties. And then last but not least, what do you do if the patient is in a treatment center or they're in jail, right? And they've stopped using, not because they've been treated, but because they're in an environment where they can't use necessarily. If they're in a treatment center, then yes, they are being treated. But what happens if somebody has continued to experience cravings, even they're no longer physiologically dependent on opioids, but they're not getting in the setting where they are, they're concerned that they might go use again, right? Either after release or after discharge. So what do you do? So the most conservative approach that I've seen is starting 1 milligram. So again, half of a 2 once a day for a week, then 2 milligrams once a day for a week, then 3 milligrams once a day for a week. So it's this like 2-month protocol where you slowly titrate somebody up. And when you get to 8 milligrams, you keep somebody 8 milligrams for 2 weeks. And then at least in this particular protocol, this was published in Drug and Alcohol Dependence, and it was for people who were incarcerated. So this was like, again, custody administered buprenorphine. And interestingly, everyone needed a faster rate. Like that was this great line in the chart, like, yeah, patients started on buprenorphine at a faster rate than the schedule. So there's another version of this where you do like, and I don't have this written out here, but it's, 2 milligrams on day 1, 3 milligrams on day 2, which is 1.5 of the 2s, 4 milligrams on day 3, 6 milligrams on day 4. Like you literally sort of go up by like 1s until you get to 4, and then by 2s every day thereafter. That you would slow if somebody is not tolerating it, because buprenorphine actually, even though it's a partial agonist, is still quite potent, right? So small doses can still go a long way. So if somebody is getting sedation or a side effect, you just slow the taper at that point. But there was this other trial in this Magura study, and this is out of Rikers, where people were started on much closer to what we would consider the standard dosing, which is, 4 milligrams, which could be stepped up to 8 on the first day. And then people could be stepped up over time. So there's not actually a ton of difference in controlled environments other than starting low, making sure that first dose people get is low, because if they've lost their opioid tolerance, they're going to be more sensitive. I can't give a talk on buprenorphine without mentioning the med first model, which is people with opioid use disorder. Opioid use disorder is too frequently a fatal illness, and people need meds as quickly as possible. And that even means starting meds once you confirm the diagnosis. But even if you haven't completed a full psychosocial assessment, conflict of interest is about to emerge, such as the ASAM criteria assessment. Thank you for tolerating my conflict of interest. But whatever comprehensive psychosocial assessment people do, like oftentimes it can take a while to get patients even ready to do that. Whereas if opioid use disorder, offering meds as quickly as possible, even if the patient is not decided to go to counseling or do other recovery activities, because it can, 1, save their lives, and 2, increase the chances that they will. That we always offer counseling, it's critically important. I'm a huge believer in counseling as a part of the treatment plan, but just like I don't withhold antidepressants from people who aren't getting therapy, or I don't withhold insulin from people who are not dieting and exercising, I don't withhold medications for opioid use disorder just because patients won't do counseling, and I'll only stop counseling if it's worsening the patient's condition. Med first does not mean med only. I'm not saying that medications for opioid use disorder are curative of opioid use disorder. What I'm saying is that they are foundationally important, that we offer counseling support with them, but that we always offer additional psychosocial supports, right? Counseling and support in addition to meds, but that we don't stop the meds or arbitrarily cut somebody off of their medications based on time frame or an unexpectedly positive result, or as a contingency of the patient's participating in counseling, but rather we're individually determining the patient's benefit. And you don't have a slide on this last point, but I'll just mention it anyway, which is one big question: why not methadone? And that's actually a really good question, because if people are really having a hard time or not stabilizing on buprenorphine in an era of fentanyl, part of it is make sure people get, give people the option, give people the option for low dose, give people the option for high dose, right? The most important thing is people get access to this medication, and we're making sure that patients understand the risk benefits and alternatives and are supporting people with the dose that's going to work for them. And so I think what is the protocol is probably the wrong question. The right question is, for whom is X or Y protocol going to be effective, right? It isn't that there is a better protocol. It's who can I work with to tolerate withdrawal? Who can I work with that just won't? And how can I individualize a plan that is most acceptable to them? Understanding the most important thing is that we get them on medications as soon as is feasible. But I have plenty of patients that are look, I've tried low dose, I've tried high dose, I've tried adjunctive medications, and it's just not cutting it. And in those cases, methadone is a reasonable alternative, as is extended release injectable naltrexone. The logistics are very different, but the pharmacology of starting methadone is actually relatively straightforward. It's a full agonist opiate. There's no precipitated withdrawal. There's no, you just start somebody on methadone and titrate up. until their opioid cravings go down and until they're, as tolerated, because methadone does have respiratory arrest risk. But I don't want to diminish the role for methadone as a treatment. It's a highly regulated treatment, right? So somebody has to go to a federally licensed OTP as opposed to the wider variety of treatment settings where buprenorphine is available. And again, naltrexone long-acting injection, reasonable option for people that really want to avoid full, agonist opioids. You do have to be off of whatever opioid you're using for like a week or longer in order to get access to it. And the lack of ease of administration limits how many people typically get on naltrexone. But again, it's a medication I use in highly motivated patients. So this is my email address, Dana. I'm sorry I was late. I was planning to do this in like 2 hours, but here we are.
Well,
And
glad
ASAM's meeting is next week. CSAM's meeting is coming up in September. The addiction psychiatry meeting is coming up in December, and INSNA's in Charleston next spring.
Yes, end of next February.
That's right. All right. So Dana, thank you for being our discussant. I'm sorry we only have 8 minutes, but let's talk about what we covered here today.
Absolutely. That was just absolutely wonderful information. There are a number of comments, I guess, in the chat. Let's see. Does anybody have a question? We have so many. Right now we have 281 people signed in with us, Brian. So if you have a question, how about raising your hand, please? Because it's maybe better to do it that way. And of course, Samuel. Yes, go ahead.
Samuela, thank you very much.
Samuel,
this was actually amazing talk. Is there any way to get the slides or if it's recorded?
Yes.
There were a couple typos I need to correct. And then if it's okay, Dana, I'll just PDF them and then you can circulate them to all the registrants or
yeah. And also just to let you know, all of our PCSS webinars after they're done, they are on the INSA website under the e-learning platform. And I have put the INSA website in the chat box as well. So you can certainly go back to it for sure. Okay, how about Melanie? Melanie, unmute your mic, please. There you go.
Hi, this was terrific. Thank you. I'm glad it went further than the usual and it encompassed everything because we need it.
Oh, good. I'm glad. I'm sorry that I was late.
It's all right. I'm almost afraid that it's too late, that we're now in the era of xylazine, plus meth, plus this, plus that. However, there were so many good protocols that I want to know, first of all, am I allowed to share these slides in order to teach people at my hospital?
Of course.
Yes.
Yes? Okay, great. And someone in here said that they were giving there were two things that I noted.
Yeah.
One was a certain reluctance, which I understand, but I certainly don't have, of letting people remain on their street opioids while inducing. And I wonder whether there's data about that. I know Boston University is doing it. I know a lot of people are doing it. I think personally it would make someone addicted to opioids a lot more comfortable to think that they weren't going to, I had a kid yesterday who thought she was in the Matrix, but said, listen, I don't want to go into precipitated withdrawal. It's like, okay. Everybody knows about it now.
Yeah.
So I wonder whether you can address whether there's any data to reassure that person. Someone else said they're giving 4 milligrams of nasal naloxone outpatient to help people switch.
Oh, really? They're putting people into withdrawal and then treating them with buprenorphine. Is that the protocol?
Not a 50. And I guess it's a nasal because she said it was Mia said it was 4 milligrams naloxone.
It's there's a certain brutality about putting people into withdrawal. We want to make sure that people really were like fully on board.
She said they wanted it.
Yeah.
They didn't do well on others. But the thing is, it displaces some of the fentanyl, but then it comes back on.
That's pretty advanced addiction treatment stuff.
Pretty cool. Thank you.
I will say I do have like 30 references in here, so I would just encourage you to like check out the references, including, and I also, for every one of these slides, I do have a reference listed. So, like for example, let's see. So like, somebody stays on full agonist opioids, using the transdermal patch method. They stay on full agonist opiates. You could also look at the Bernese method, which is easily searchable online, but the links to all of these protocols are in the bottom of the slide. So happy to distribute them.
Thank you so much. Dimitri, what's your question?
Hi, thanks, Dr. Hurley. Great presentation. So I'm working in Santa Cruz County where there's where we have a jail.
Yeah.
And one of the things, WellPass takes care of the patients in jail. And there's been a lot of contention about dosing of people that have already withdrawn from opioids in the jail setting. And the patients come out complaining that they're not getting a high enough dose of buprenorphine while in jail. But the doctor that works there has a fairly good argument, which is, so we're people may have cravings at the lower doses, but there's really minimal access to opioids in that setting. So
is that true?
Well, they're working hard to make sure.
County jail. It is not true in LA County.
Yeah, no, it's not like LA. I trained at LACUSC Medical Center, so
okay.
It's not there.
Okay.
But I just wanted to hear your take on that.
Yeah, what I'd say is I would much rather a patient be on a little bit more buprenorphine than is the absolute minimum. And if they're more comfortable, I think that's a better approach. If there really is a good reason to artificially suppress the buprenorphine dose in custody, make sure they're on a therapeutic dose on release.
Yeah, that's what they do. That's what they do.
But I would not be trying to suppress the dose in custody is my answer. And the Rikers team, which is 4, 8 up to 32, you know what I mean? Kind of like that's like standard patient dosing. That's what I gravitate towards. The reason I put in the ultra low dose starts was 1, because it is a published protocol, and 2, and everyone needed something faster. You know what I mean? Patients started on we had this low dose protocol and everyone needed to be accelerated on it. That was the point of my sharing it that way.
Okay, got it. Thank you.
Thank you. Parmas, what's your question?
Yes, good morning, and thank you so much for this excellent presentation. Quickly, I just wanted to ask, and a disclaimer, I work at an OTP.
Yeah.
In our experience, methadone has been more effective initially, or many patients who are started on buprenorphine end up requesting methadone. Is there an argument to be made that methadone is more effective, although not as available as buprenorphine when it comes to severe?
Wow.
Okay.
We don't have an RCT proving that. So I can't tell you that. I can't say all the studies on buprenorphine versus methadone were non-inferiority studies done during heroin, right? You know what I mean? So,
right.
But is there an argument to be made? Absolutely, there's an argument to be made. Particularly if we're going to see increases in precipitated withdrawal, and if methadone solves the problem, if it doesn't precipitate withdrawal, then is an argument to be made for increased methadone access? Absolutely. I do also think there's an argument to be made, but we should make sure that if we're going to transition somebody to methadone, right? And buprenorphine would be a better drug for them for whatever reason, right? Cardiac arrhythmia reasons or whatever. Give somebody a real shot at a big dose of buprenorphine. Don't be like, oh well, we did the standard dosing, it didn't work, so buprenorphine is not for you. Try low dose, try high, try alternatives before you give up on buprenorphine necessarily. But I do also think there's a case to be made for methadone because of the ease of initiation. Does that kind of distinction make sense? Don't give up on methadone too early, or don't give up on buprenorphine too early. But don't forget about methadone either, is kind of the point I'm making.
That's really good. Thank you so much. Much appreciated.
Well, let me get my typos corrected and then PDF'd, and then I'll work with the ISNA team to get this out. And again, I'm so sorry I started 20 minutes in, but I'm just really glad that we had the time here together.
I think, Brian, that you made it up. I really do.
Oh, thanks.
I mean, this has just been really incredible information. I know I've heard things that I had not heard before, and your reference list is really, really fantastic. Thank you so much.
And Melanie makes the point, you can get to higher morphine equivalents on methadone than you could on buprenorphine. That's true. There are people who really that is another advantage of methadone, is you can get the higher opiate effects. So again, I want to honor. You're right, Matt. You're right, Melanie. Thanks.
I think it's a fascinating thing to think that methadone can be even more effective, but it's just not as accessible because
that's exactly
of the way, that we've set it up. And federally qualified methadone clinics. But thank you so much.
Thank you.
Wonderful. For everyone, you'll be getting a survey after this, and if you complete it, then you will get your CEUs. If you have, if you're in a profession to take the nursing CEU, well, the nursing CEUs is what we offer here at INSA. And we will. So, Brian, you're saying you're going to change some things, and then we should.
I just a couple typos for my vanity. I should get this done in the next hour. Thanks.
Okay. That's fine. That's fine. Well,
All
thank
right.
you, everybody, for
Thank you,
being
everybody.
here. Very happy you've been here. And let us know if you have any other questions.
Thank you
Okay.
to ISNA for hosting this. I think this is such an important topic. So thank you.
Absolutely. Thank you for accepting. Thank you for doing it. It was wonderful.
All right. Take care.
All right. We'll see y'all later. All right. Be safe, everybody. Bye-bye.